good morning. It's a real pleasure to have him here today, visiting professor. We will talk about the psychological treatment for sleep problems in healthcare, step care, and adaptive treatment. And we have here with us Professor Susanna Jernelöv. She's a licensed psychologist and associate professor at Karolinska Institute in Stockholm, Sweden, and a specialist in cognitive behavioral therapy for insomnia disorder. The last 15 years, she has focused her research on psychological treatments for sleep problems and sleep disorders. She's currently involved in projects evaluating CBT for insomnia and other sleep difficulties in psychiatry population, predicting outcome and adaptive ongoing treatments to improve treatment outcome for patients at risk of treatment failure, mechanisms of CBTI, and digital solutions to increase the access to CBTI. She's also authored books and book chapters on CBTIs and trains professions in it. And to start, we have a little presentation of Arthur Caye, his general manager of CISM, a big research program that he will present now for us. And then we will carry on with Professor Susanna's presentation. And at the end, we have some time to question and to interact with her. So thank you again, Professor, and thank you, Arthur, for coming here.
So good morning. Thanks a lot for being here, for your presence. Thanks, Susanna. So they gave me a very challenging mission of giving you an overview of the National Center for Research and Innovation in Mental Health. This is... Eu acho que está desligado. Você quer que ligue, talvez?
Melhor desligar. Você tinha que estar baixo.
Eu ligo.
Better? Okay. So the National Center is one of the biggest projects that we have in mental health in Brazil, so I think it's very hard to present in 15 minutes. I accept the challenge. I'll try to give you an overview. So one of the things that is important about the CISM, as we call it, is that it's an initiative led by researchers here at USP, but also with partnerships from other top universities in mental health in Brazil, like UBIS and FESP. And a novelty is that we not only count with public funding this time with FESP, but also with private donors, including in the Industrial Bank of Brazil and a private institution in São Paulo. There are some motives and reasons why we do this, and I think all those things are you know a lot about it, that common disorders are very common. They are invariant, they are chronic, they are hard to predict, hard to prevent. We have evidence-based treatments, for instance, here at IPT, but one of the challenges is that our treatments do not reach most of the people that need them. So CISM is based on these three predisposing challenges. Okay, so we decided to tackle these challenges with three modules, several projects aggregated in three modules in mental health. The first one, population neuroscience, aims to understand what are the determinants of mental health, the risk factors for mental health of young people. And we do that through a design of a community-based cohort. So going back in time, 13 years ago, we went to 57 schools in Porto Alegre, São Paulo. We interviewed 10,000 families. We selected 2,500 kids. These kids were then 6 to 15 years old. And we collected lots and lots and lots of information about them. Not only phenotyping, so we interviewed the psychologists with themselves, the parents, but also MRI, genetics, a lot of biopsychosocial information. So really lots and lots of information. And we have been repeating that every 3 years, so that now they are young adults. They themselves, some of them have kids. And of course, many of them develop anxiety, depression, and other mental health conditions. And the nice thing is that we can go back and learn about how were they like when they were kids, what were the context, biopsychosocial context, what happened to the brain during that time. So a lot of things have been already done with this data set, more than 100 scientific papers. I won't go into details, of course we can chat later. I think the exciting thing is that with CISM, with this new funding, we can do a lot of new and even more advanced things, like with new follow-up waves. So one of the examples is to do basic data collection, so to use the cell phones to monitor how much they type, how much they spend time in each social media, how do they move throughout the city, and other factors. We are also studying 3 generations, so interviewing their parents and the kids, not the kids because they're too young, but about them, right? And some of the phenotype of, the genotype of 3 generations. This is something that is so much advanced if you look at other cohorts in the world, that it's really proud to have here at USP São Paulo, so it's very, very nice. But we have to hurry up. So we have module 2. So module 2 is about digital mental health and the idea that we can use technology and the advance of technology to help us to tackle that challenge of lack of access or lack of effectiveness or lack of difficulty to prevent those mental disorders. But of course, we are an academic institution, so we have a different touch to digital mental health. So you probably know that in App Store or Google Play, you have like thousands of apps that promise to alleviate anxiety or give nice tips about ADHD. But what we know is that less than 2% of those apps are backed up by any evidence. So it might be that they do the opposite, or maybe it just don't work. So our approach to that is to run pragmatic trials, so real-life scenario trials with new technologies, mainly apps, to see if they really are delivering what they promise to. So one of the examples is this app is developed with partnership with the WCU, Washington State University, which is the targeting patients with alcohol use disorder, and the app connects to the portable breathalyzer, so the patient has to provide 2 samples a day, and he or she receives feedback like a prize, for instance, a gift card that is cumulative over time. So the more he or she stays abstinent, the higher the price, which is continuously management, but translated to an interactive feature and not going to the hospital and do breathalyzer like we do regularly, right? The second approach is to really try to pave the way for new technologies to come in through a thing that we call the Grand Open Innovation Challenges. That's created by other people. We are adapting that to Brazil, but we're having the first one actually tomorrow in Jaguariúna, and I'll try to explain a little bit the process. So what we do here is first to hear stakeholders, to really hear from the population, and that includes patients, families, health professionals, school teachers. What are the big problems that they want help from technology to solve, in this case for young people? We did that in Jaguariúna. It's a city that we are partnering with. I can tell you a little bit more later. And the 3 challenges were depressive symptoms, drug use, and bullying. And then we selected from several startups and teams of technology the best solutions. Those were the semi-finalists. And tomorrow we will have like a contest in which we will select the best ones to then try to further develop the solution, prototype, run a pragmatic trial, and maybe come back to the city with this solution and see how it goes for the population, if this is really something that we can implement. Then we have module 3, that's my personal favorite. So module 3 is about implementing things that we do in research a lot for the public health system. So really to understand how to reach those people that are in need, right? This comes from a rationale that I didn't know before being involved in CISM, that less than half of the interventions that we prove effective in medicine, not only in mental health, ever reach clinical practice. So we do a lot of research, not so many are implemented, and it takes an average of 20 years, so lots of time. So implementation science is a field that uses research to understand how to reduce this gap. We are partnering with two medium-sized cities in the countries near Campinas. It's two are right from here. One of them is Abertura, Jaguariúna. They are really wanting to receive this technology and involve healthcare professionals with us, with researchers, so that both are collaborating to try to implement those interventions. I won't go into details of all of them because of time. I just want to give you like an overall feeling of what we're doing. We have one nurse visiting program that takes care of pregnant teenagers and their babies for 3 years. That's called First Eyes or Prenatal Laços. We have one mental health literacy intervention for school teachers, teaching them how to deal with the main health issues that we have in schools, such as bullying, but also depression, ADHD, and others. That's called Love Your Mind or in some English. We have one project in the university in which we measure mental health symptoms of university students, and we want to use that data to maybe design interventions focused on the main problems and specifically for this population. We have another one that's a new one actually, to improve quality of care, in which we aim to train primary care professionals in evidence-based management of common mental disorders, and also to try to establish a protocol on when and how and why to refer a patient, a complex patient, to a hierarchy of and complexity of care. The main one in this case, because of Susanna's talk and presence here, is on NYCBT. This is a stepped care program. It's a digital care that tackles common mental health disorders in primary care using components of CBT that we know it's a cost-effective intervention. So we are targeting 3 domains of symptoms: anxiety, depression, and insomnia. Those are common, very prevalent. They are transdiagnostic in a way also. And we are basing this approach in a work by our team, and Paulo, who is here, was the main who led this study that showed that in primary care in São Paulo you can have a significant clinical response in 41% of cases only using a very cheap, scalable, self-guided behavior intervention through an app. So this is really with literally almost no cost, and you can solve not all, but a big proportion of the cases that we see in primary care. So what we are proposing here is to go beyond. So we are doing a first phase called phase 1, which is self-guided, so completely scalable and cheap for insomnia, not only depression, but also insomnia and anxiety with other techniques based on CBT. And then for those who do not respond, we have a phase 2, which is then therapist guided through the internet, more efficient. One therapist, at least with here, has the experience for OCD, but one therapist with this tool can take care of 4 or 10 times as many patients. So it really increases the reach, and not only the effectiveness of intervention. So the study goes like this: recruiting patients in primary care units with high levels of depression, anxiety, and insomnia. All of them receive self-guided CBT intervention targeting those symptoms. It's symptom specific, right? So you only receive interventions for insomnia if you report insomnia, anxiety, depression. And you can receive all those 3 at the same time. If you improve in all domains, the patient then is referred to individual care, otherwise it is eligible for a phase 2, where we will then randomize, and we will randomize because we do not have although we have evidence for ICBT around the world, we don't have specifically in this population in primary care. So at this point, we're doing a randomized trial, this phase 2, especially because it's cheaper than usual care, but it's still not so scalable. It needs therapists. So in summary, Module 1 is on quantitative determinants of mental health. One of the projects, for instance, found that poverty, abuse, and neglect are associated with psychopathology in children. Module 2 aims to develop and test technology to prevent or treat those mental health issues. We have one other app, which is Moderately, that prevents modern depression, which is also risk factor for neglect. And the third one is to implement those technologies in the public healthcare system. So we have nano-ICBT, perhaps we can implement Moderately if we have evidence of efficacy, and we're already taking care of the months with premier class or first test. So, thanks a lot for your attention. I invite Susanna to join me. Please.
So hello everybody, and thank you so much for having invited me here. I'm really pleased to be here. My name is Susanna Jernelöv, and I am a clinical psychologist and an associate professor at Karolinska Institute, and I've been working for a long time with treatment for insomnia, so mainly CBTI, and I have been working also a lot with digital treatments for this disorder. And I will talk to you today about psychological treatment for sleep problems in healthcare and digital delivery, slept care, and adaptive treatment. And you will soon know what all those things are. So Karolinska Institute is where I am, and we have a cool new, relatively new building for the aula. And this is Stockholm, so if you ever get a chance to come and visit, please do. And like I was saying, I will talk to you today about psychological treatment, and I will talk a little bit about what cognitive behavioral therapy for insomnia is. And actually, I don't know if all of you know what insomnia is, so I'll talk about that as well. And evidence in that international guidelines, and then digital CBTI, slept care, and adaptive treatment strategies. And I just realized I don't have the time. So if somebody will let me know if I'm going over time, I would be very happy. So, psychological treatment for insomnia. What is insomnia? Well, insomnia is, when I talk about it, it's a disorder. Sometimes it's talked about as just symptoms, but when I talk about it now, it's about the disorder. And you can find the disorder criteria in different manuals, so either, for instance, the DSM, Diagnostic and Statistical Manual for Psychiatric Disorders, or the ICSD, which is the sleep equivalent, or diagnostic manual. It all has to do with difficulties falling asleep or staying asleep. And this nowadays has to occur despite adequate opportunities for sleep. So unless you actually have a good place to sleep and have enough time to sleep, you cannot get a diagnosis, which I think is important, not least in the project that you're doing. You also have to have daytime symptoms in order to get the diagnosis. So if you only have problems during the night, but it doesn't affect your day, you cannot get the diagnosis. And also, since the DSM-5, then comorbidities may be present. So until the DSM-5, if you had comorbidities, you couldn't get a diagnosis of primary insomnia, but it was sort of complicated. But now I think this is a very good development because people usually have comorbidities. It's quite rare in the clinic to see patients with only insomnia, from my perspective. These difficulties have to be around for at least 3 times a week and for at least 3 months. So it's quite a long time period, but again, in the clinic, it's quite rare to find patients who have had their problems for only 3 months. It's quite common that people wait a long, long time before they seek help. So usually our patients have had their problems for maybe 10 years or even longer before they seek treatment. And it is very common in different international studies. You usually see about 25% with nocturnal symptoms, and if you look at nocturnal and daytime symptoms, it's lower, of course, but it's still about 10%, and somewhere around there we would probably get an insomnia diagnosis. So I was saying you need daytime symptoms in order to get the diagnosis, but some of the consequences of not sleeping well during the night, of course, are fatigue. And low mood and depression is also very, very common. And lowered functioning in everyday life, both in work and in social settings. And there's a lot of presenteeism and work absenteeism due to insomnia, so there's a lot of costs associated with this disorder. And so clearly, like I was saying, that of course depends a lot on the system in which you work. So in countries where sick leave is an option, sick leave is higher. But if it's not an option, or if you risk getting fired if you're away because you're sick, then you may be present and sick, or very not well functioning due to your insomnia. So deteriorating mood also, and not least economy, so both on a societal level and for individuals. And a few years ago, or quite a few years ago now, the group in Oxford, Simon Cowell and those people, they did a qualitative study looking into what people were thinking about it. And it's really clear that although as working in psychiatry, you might see insomnia as something, or sleep problems as just part of the bigger problem, the patients with insomnia really find that it's a huge thing. It's something major that stops you from functioning every day. So insomnia without treatment is very persistent, and in longer cohort studies, if you follow patients up, insomnia is persistent in, well, depending on how you diagnose it or how you define it, in 31 to 69% of cases. And what has also been found is that the more prolonged and the more severe the degree of insomnia, the lower the probability of spontaneous remission. So sleep problems are very chronic, if you wish, but not chronic in the sense that you cannot cure it. It's just chronic in the sense that you need help to do it. So sleep problems often vary over time, but they're generally persistent over a 20-year period. Okay, so psychological treatment for insomnia. The treatment with the strongest evidence is CBTI. And CBT, as you may know, is cognitive behavioral therapy, and CBTI is what we call it when it's for insomnia. And this is quite interesting, I think, because we usually don't call CBT for depression CBTD. Sometimes it's done, but not very often. But CBT for insomnia has gotten this particular little description, or CBTI, that's it, cognitive behavioral therapy for insomnia. And like any CBT, it's based on learning theory and on cognitive theory. So both the learning theory of the first wave of behavioral therapies and the second wave are sort of combined to CBT, which is what we usually see today. But from a historical perspective, I think this is really interesting, obviously. There's a focus on feelings and behaviors and thoughts here and now, so not much to deal with what happened in the past, and this you know. It's also always a very structured treatment, and it's usually got a lot of homework, so patients really have to work in between sessions to have done their CBT. In CBT for insomnia, CBTI, we use general CBT techniques, which can be used in treatments of many different disorders, like relaxation or cognitive restructuring, which is used in most treatments of CBTI, depending, of course, on the analysis that you do for the patient. But there are also two important models specifically for CBTI, which is the two-factor model of sleep, which maybe not everybody is familiar with, but it has to do with the circadian rhythm and the sleep pressure, so how they are interacting with each other. And then there's also specific CBT models for insomnia that deal with the specific things that are important in insomnia. And then we have specific treatment techniques specifically for insomnia that are not used in, for instance, treatment of depression or anxiety. And that is specifically sleep window work, which I like to talk about. Originally, we talked about sleep restriction, that's the term, sleep restriction therapy. And that's a terrible word because it really, partly because other sleep researchers talk about sleep restriction and mean something completely different. They mean that patients actually don't get to sleep. And when we talk about sleep restriction, we talk about the therapy whereby you work with a sleep window. So I'll get back to that. And the other one is stimulus control, which can also be, the term can be found in other CBT treatments, but the way we use it in CBTI is specifically related to sleep and the bed. So using CBTI, effects are maintained in the short term, up to 3 to 6 months after the end of treatment, you see that treatment effects are maintained, which is nice. But we would like for our treatments to last longer than just 6 months, or we need to treat people again. And we've done a few studies looking at that, and we found that CBT is effective still after 3 years after treatment. And that I think is quite nice and impressive. We also looked at the effects 10 years after treatment, and the effects are still maintained at a much lower level. So I think this is something that's a really unique selling point when it comes to different treatments for insomnia regarding, because when you look at pharmacological treatments, when you finish treatment, which shouldn't last for more than 4 weeks, insomnia usually comes back. However, we know also that pharmacological treatments are usually not finished after 4 weeks, as in the guidelines. So people are usually still on pharmacological treatment after many years, and whether that is effective or not, we don't have scientific evidence to prove it. There's clinical experience saying that for some people it may work, but we also know that it's related to a lot of dependence and lowered effectiveness of the treatment. So that is a problem. So I like this. I like that we can show that after many years, after a 6-week treatment, we still have good effects. And that is nice, but it's not for everybody, but we'll get back. So international guidelines are all very unanimously saying that we should use CBT as a first-line treatment for insomnia. It's recommended by many different associations, like the National Institute for Health, American Academy of Sleep Medicine, the British Association of Psychopharmacology even. They recommend CBT as a first-line treatment, even though it's pharmacological treatments that they're aiming for. The European Sleep Research Society, Australian Sleep Association, and American College of Physicians as well. I don't know if you have Brazilian recommendations, but actually in Sweden we don't have national recommendations, which is interesting. We're working on that. So, but this is true. However, those patients who receive any treatment at all usually receive pharmacological treatment. It's much more common than psychological treatment for insomnia, unfortunately. So our research questions have been really into how can more people get access to and benefit from CBTI. And of course, like Andrew was saying, we use digital CBTI. And our first digital treatments in Sweden were developed and implemented in regular care in 1999, so that's quite a while ago. And at that time, internet wasn't really very much used. People were not using Facebook, they were not using Instagram, all of those things. So the internet-delivered treatments that we started off with was basically self-help books that we took, and the materials, we took them and put them on the internet so they could be accessed from anywhere. So that was our start. That's where we started. And now, technology is developing and everything, so there's many different versions of digital CBTI. When we talk about digital CBTI, it can mean an array of different things. And these are some examples. I think I covered most of them, but I didn't put apps in here. So some of them is what we call therapist-guided internet-delivered CBTI, which is iCBTI. And like I was saying, those are the mostly text-based, so those are the older versions many times. And they're usually static, so they're not adaptive to different screens, for instance, or they may be, but they're sort of more simple in that sense. And but that is still what we use in our clinic. So we have an internet-delivered treatment clinic, and we use those types of treatments because we know that they work. Even though they're quite basic, we know that they work, and we use asynchronous written interaction with therapists during treatment. And then we have digital CBT with automated support, which is the big ones in Europe and the US are Sleepio or Caye or Sombrist, for instance, and they're media-rich usually. So they're sort of a second development from this basics that we have been using for a long time. The content is usually automatically adapted according to the patient responses and things like that. So patients will respond and the content coming after will be adapted, which is nice. And usually you have no therapist interaction during treatment. Nothing written nor spoken. And then we have developed the simplified self-guided brief digital CBTI. So digital self-care, which is also usually text-based or video-based, but it's still the sort of basic, not so complicated technically. And they're partly adapted to patient responses. And we also have automated reminders, which are just general reminders. So they're just reminders to fill out a sleep diary, for instance. And we have no interaction with therapists during treatment. But there's also video conference digital CBTI, which is well, just regular treatment, but via video. Sometimes it's called e-health, and sometimes e-health includes a lot of other things as well. And that is all synchronous, so it's just like any regular meeting. So I have some just illustrations on this. How is CBT carried out in practice? Well, you assess and analyze a problem, you educate the patient, you give them a rationale for the method and tailor it to the patient. Patients may get in-session practice, and you plan for homework. And then patients go home. They practice homework, they register things, behavior, thoughts, emotions, and symptoms, and then you evaluate. And usually this is done in an iterative fashion, so the next session you sort of do the same thing again. You plan for the next one. And in regular CBT, this is carried out in face-to-face. Now this may be different schools of psychology according to and involved in this, but CBT, of course, based on learning theory and cognitive theory. And the patient goes home and works, and then you come back and you discuss this and do the evaluation. So if you compare this to ICBT, you have the same exact steps. You practice homework at home and you evaluate, only you get to do this via the internet. So patients do this themselves. There's no in-session practice, of course, because there's no session. You may or may not tailor it to the patient. Like I said, our old versions are not so much tailored. And the patient goes home and works on it. And again, writes something on the computer, and the therapist is sitting with their computer, sending text messages. And in our versions, the patients also fill out assessments. For instance, if this is depression, so they may use the MADRS or the PHQ-9, and for sleep problems, they use ISI. And these results go back to the therapist, who may act on them. And then at the end of treatment, the patient evaluates, and this information is given to the therapist, who will then respond to the patient. So it's all written messages, it's all on the internet, and it's all asynchronous. Okay, so when deep CBT is carried out, you just completely eliminate the therapist in all of these steps. So no therapist at any of the previous therapist steps. So take them out there, still don't tailor it to the patient, take them out here, take them out there, but otherwise the patient does the same things. Usually they fill out assessments during the treatment, and they fill out a report. And this may go, of course, into some sort of system, and there may be therapists behind it, and in some cases you have someone who sits there and reacts to, for instance, if patients indicate suicidal ideation, there may be someone there, or they may not be. Depends on the system in which this is implemented. Yes, and if this is DCBT, you don't really have an analytic phase in the same way either. It's more of a general, we have already done an overall analysis. So compare this to the digital self-help or self-care, then you completely abolish all of these except the assessment. And then the patient works with a digital tool for a number of weeks, which may be 3 or 4 or 6, depending on the tool. And then they evaluate on their own, and this is fed back. So all of these should have crosses on them. Sorry, didn't work in my presentation. So these are all crossed out. You don't have this, and you don't have this. The only thing you have is the patient working digitally on this treatment. And when it comes to e-health, you have the same thing as, like I said, a regular face-to-face treatment, but you have it on screen instead. So you do the same things, it's all synchronous, and you do it on screen. So when we've looked at this type of treatment for insomnia, we've looked at the internet-delivered therapist-guided versions to begin with. And this is the full-scale internet-delivered treatment with therapist guidance. And we see that the results are very good compared to control treatments. We see very good, large differences right after treatment. And these differences are still maintained, but diminish over time. And when we compare it to group treatment, so this is still the internet with the therapist support, asynchronous. We find that it's just as good as group treatment. So no difference to face-to-face group treatment and internet delivered. So that's very good because, as we were saying, we can have more patients being treated by the same therapist, even though they get therapist support. So in meta-analyses, internet-delivered CBTI produced good effects. You see reduced insomnia symptoms, improved subjective sleep, and sleep metrics. And the effects are often comparable to face-to-face CBTI. And like I showed you before, the effects are lasting in the long term, as for face-to-face. But what we do see in meta-analyses is that dropout may be a large problem. So that is something we need to think about when we want to implement different types of treatment. And in these meta-analyses, we also saw that, or it was also seen that longer treatment periods and higher degree of individual treatment support correlate with greater treatment effect. So that is something we also need to think about. So it depends on where your interest lies, if you wish. If you're interested in the individual patient, then we may need therapist support. If you're interested in a more global perspective, then maybe a fully digital treatment is more useful. So there are many digital treatment programs and apps out there, and like you were saying, many of them are not evaluated at all, so that's a problem. We would need quality review and quality assurance, but whose responsibility is that? This is a market, so people may buy what they want. So, stepped care I want to talk about. So the problem is, of course, we have a lot of patients, and how can we help as many patients as possible given the limited resources we have? So all of these patients are sick, and we have to help. So the stepped care model says we can use different levels of treatment in a stepped fashion. So the lowest step, you distribute, for instance, digital self-help of some kind, and if this doesn't work, then on the next level, you may use manualized group treatments, for instance, for patients, and this has been suggested and can possibly be delivered by healthcare staff that may not be specifically trained in CBT, but they may be trained in CBTI and in that particular manual. That has been tried, for instance, with nurses. And at the highest level is where the patient gets to meet a psychologist specifically trained in CBT and CBTI and possibly behavioral sleep medicine as a larger field. And so the patient, if something doesn't work, you start on the bottom, it doesn't work, you review the effects, and if it didn't work, you refer on, and so forth. So this is a nice idea, nice model, I think. And then you can look at other things in relation to the stepped care model. For instance, the clinical level where you could recommend treatments for insomnia disorder, and somewhere you have to get the diagnosis, and that's usually outside of the stepped care model. And pharmacotherapy, as we know, is very much used, and it's also not in the stepped care model in this case. And then we also have a preclinical level where we want to work preventively. So in schools, hospitals, workplaces, and this may be done also possibly outside of this model. So digital treatments as a first step is a good idea, but digital treatments, as you saw, it can be just as demanding for the patient as a face-to-face treatment. They still have to do all of the things that they're supposed to do, but it's demanding and you have to do it on your own with less therapist time at least. So this is something that we were very interested in. So how does that work if we want to, can we simplify treatments from the patient's perspective and still get good enough results? So we tried a digital self-care, which was a very simplified two-component treatment without therapist support, which is, I think, in the phase 1 in Europe. And this treatment, we saw that, so this is the insomnia severity index, which divides patients into different levels of insomnia symptoms. And the darker the color, the more severe the problems. So before treatment started, 100% of the patients were in the more severe levels, because that's what we said, you have to have insomnia at a certain level to be included in the study. So above 15, and some of them also above 22, very high levels. And at pre, since patients usually seek treatment at a point where they're really unhappy with their sleep, and this can fluctuate, then usually you see a little bit of improvement from screening to pre-treatment. And this is what we see here as well, but the majority is still very bad or poor. They're sleeping very poorly. And then after just 2 weeks, we see a marked improvement where the severe cases have completely disappeared after just 2 weeks of this very simple intervention. And the majority has the subthreshold insomnia, and no clinically significant insomnia is increasing. And we see that this continues. So at post-treatment, it looks quite similar, only the moderate severely have also diminished a bit. And at 3-month follow-up, we have continued improvements, which is very nice. So this is something that was very encouraging, we thought, and we wanted to use that more. So we want to work on ongoing studies with that. So a note on this is that the patients were self-recruited. They're Swedish participants, they all speak Swedish, and they were recruited via social media in a very simple fashion. So they're highly digitally competent, and they have a very high education level. And there was for us, it was unexpectedly high spontaneous adherence to the treatment, although we did have daily text message reminders. So people filled out the sleep diary that we had for very many of the days that we wanted them to, so much higher than we usually expect. And also very high adherence to study measurements, but there we also had very active assistants. So perhaps this group is not representative for other patients in other contexts, so patients in healthcare and other groups, for instance. So, and some of the problems with the stepped care model, like I was saying, how do you know which level a specific patient should enter on? Should everybody start from the bottom? Should we give this type of simplified treatment for everybody? And then if it doesn't work, then work their way up? So, does the patient have to go through a whole treatment before they go to the next step? And this is one of the reasons we want to make this very short treatment, because we think that it's a bad thing if people have to fail treatment. If you go through a long treatment, like the sleep and Somris, they're 8 or 9 weeks, they go through that whole treatment with basically all the treatment components in CBTI. Then what happens after failure? How motivated is a patient to try the same thing but on a higher level? And also another question is, when are we done trying? How long should we continue this before we stop trying? And what do we do then? Is it sleeping pills? So this is something we don't know. And a way to try and overcome some of those problems is to predict the future. So we want to know who can actually benefit from our treatments. We'd like to know that beforehand, but that is really difficult. So, the question is, before choosing a treatment, which treatment will give the best effect for that patient? But we think that we can also look at things early in treatment. Will this treatment work? So predictions before treatment begins is really difficult, and it's work in really early in the process. And we have two perspectives, like I was saying. Will treatment A work for patient X, or will treatment A, B, or C work best for patient X? It would be nice if we could say, oh, this patient needs the highest level, and we can put them in there immediately. Or this patient will be fine with just the basic digital CPI or self-care. So 1 is the most common question, and 2 may be more useful and more ethically sound, especially if it's highly uncertain. So we wanted to look at this in an adaptive treatment, as an adaptive treatment. And that means that we do predictions, because the predictions beforehand are so difficult to know. We haven't really found any strong predictors of treatment outcome. So all the regular ones are not very useful. So gender, education level, all those things are not very useful. So we wanted to do a trial where we looked at that. So this is the basic idea. You start with a patient, a sick patient, which is insomnia. It doesn't look like it, but it's a patient with insomnia. And within the treatment, you put in the first gear. And you follow the treatment progress, and if it doesn't work, you put in gear 2. And you follow treatment progress, and if it doesn't work, you put in a 3rd gear. And you follow treatment progress. And if this works, then all's fine. But if it doesn't work, you may want to step people up already within that treatment to the next level. So you don't let go of them before you give them another option. And this treatment may be, it may be ACT, it may be other things, it may be more intense CPI. So that is something we want to look at. The ideal solution, of course, would be that you can match patients to treatments to begin with, and then still do an adaptive treatment strategy where you predict patient outcome, and you see if it's not working, then what is the problem, and you continue just adjust treatment, or you give a new treatment, and you look at it from interaction. So that would be nice, and that could be called maybe accelerated care. It's a suggestion. And we did research to evaluate and do a proof of concept on this adaptive treatment strategy. So we gave internet-delivered treatment for insomnia. So, like I said, the basic and therapist-guided, a lot of information. And it was a 9-week treatment, and during week 4, patients were assessed. So that was the figure I showed you before, where we assessed them, how is this working? And we divided them based on the assessment into red patients and green patients. Another Swedish for green, sorry, I missed to translate that one. So the red patients were predicted to fail, and the green ones were predicted to improve from treatment. And then we randomized the red patients only. So we took out the red patients and we randomized them to continuous regular treatment or enhanced treatment. So this is what it looked like. The classification was done in week 4, and patients were then randomized to red or green. And the green ones just continued with a regular ICBDI, just as we always do. And the red ones were randomized to either ICBDI or enhanced treatment. So half of the red patients were given enhanced treatment. And in the enhanced treatment arm, we did a telephone interview to analyze and solve the problems. So we left the purely written as asynchronous setting, and we did telephone interviews. And after the interview, we asked specific questions, and we did a functional analysis of the patient's problems. And then that resulted in an individual treatment plan, and most patients wanted more therapist support. And many of them wanted therapist support via the telephone rather than just written messages. So that was one of the things. Some patients also found the internet format, even though it was very simple, they found it to be very difficult. So we would print the material and send it to them on mail, just print it, or it could have been a book, but we printed and sent it to them. We could also have sessions with an expert, that would be me. So patients could meet with the sleep expert and get to talk about their sleep problems. Or we could have new modules that would look more into how to handle specific treatment-related problems or aspects of insomnia that were not included in the regular treatment modules. But all was still strictly insomnia focused. So patients could have many other problems. They could have anxiety or depression or many other things, but we still focused on insomnia. And these are the results. And as you can see here, this is after the classification. These are the red patients. They are obviously higher to begin with because that was one of the criteria. We thought that patients who started off at a higher level might be worse off, so we included that in the algorithm. And then the weeks were happening, and at week 4 we did the classification, and they were randomized. And then after that, the red patients with the standard group continued, and they didn't do as well, and the red patients with the adaptations did much better. So they started following the trajectory of the green group. So we think that if we had continued, we might have had better results. It's equal results for these patients. And when you look at the failures in each group, we had in the green group about 23% of patients who did not reach the success threshold. And in the adapted group, 37% didn't, but in the red standard group, 64% of patients did not remit. So that was a proof of concept that it can work. So we could see that non-responders could be identified a few weeks into treatment, and non-response is avoidable with adaptations to some extent. So the predictions are not perfect, and the effect of the enhanced treatment is also not perfect. So there's more work to be done. This is also a Swedish word. Sorry, that means conclusions. So CBTI is an evidence-based treatment method that is recommended as the first choice for insomnia. And CBTI is not used widely as it should be. And by applying a stepped care model where, for example, digitally delivered treatments are a first step, more people with insomnia can receive CBTI. And it's very difficult to predict which patient will benefit from the treatment or which level of treatment before starting the treatment. So adaptive treatment strategies may be a feasible route within the framework of the care model to reduce the risk of treatment failure and improve treatment outcomes. So thank you for your attention. This is a research group out in the forest.
Thank you very much,
Thank
Susanna.
Should I take a question?
Yeah, if you want to sit here.
Okay.
So thank you again for your wonderful presentation. And now we have some time for a few questions. If you want to ask her something or any comments.
Thank you very much for that lecture. Sorry, but I know that is not focus on Could you tell us more about where the design comes from?
Sorry, where?
If you could tell us more. Microfone. Por favor, senão a gente está em casa não escuta. É melhor descer.
Thank you very much for the lecture.
Thank you.
I know that's not the focus of the presentation and therapy, but since you're studying insomnia and sleep in general, if you could tell us more about where does insomnia come from?
I guess I can use this one, right? So, well, where insomnia comes from, that's a very good question. And I guess anyone who can answer that will be very happy. It seems like there's a strong, or it's at least a genetic component. So it's you're more likely to have insomnia if one of your parents have insomnia. But also from different stressors. So most patients will tell you that my insomnia started in this situation. I was having a terrible situation of some kind, a lot of stress. It could be emotional stresses or just life-related stress in general. So that is something that you can see very often. And what was I thinking? Yeah, well, so those are I think, biggest things. But it's interesting because when we do CBDI, we don't really, we of course we talk about this, but it's not something that we then work on. We work on the how, here and now. So that's much more prevalent in that way. But that was that. Yeah.
Thank you for your presentation. In the adapted phase of the adaptive treatment strategy, you mentioned a variety of options. And how was it done in the study? Each patient would choose the adaptation, or it was randomly assigned? How was the adapted phase conducted?
Yes, we did the interview with everybody, so all the RED patients were interviewed. And during the interview, we did an assessment and a behavioral analysis, so of the patient's problem. And based on this functional behavioral analysis, we, together with the patient, decided on what they might need. So it was very individualized in that sense. And this interview was quite brief. It wasn't very long. I think most of them were in between 15 and 20 minutes, but some were longer. And in some cases, I found that really interesting. And in some cases, the patients just wanted to talk about how difficult it was, how much problems they had, and then they were done. It was like they just had to get it all out. And then when we were looking at, so what can we do? And they're like, I think I can continue like this. I don't have to have anything else. Okay, so do you want me to maybe check in on you? Should we be on the phone? We can try that. But so not everybody wanted very big adaptations. They more wanted to be maybe heard in a way that they didn't feel that they had been in the digital communication. So I thought that was interesting. It wasn't maybe the largest group, but it was definitely one group. So all the adaptations were individualized.
Susanna, thank you. Excellent work and a very clear presentation. And it will help a lot what we're planning to do here. So I have two questions. The first one is related to the setting where this study was done, whether it was it came from the primary care network in Sweden to recruit patients or more specialized services, because this is one of a key issue for us. We'll work with essentially primary care clinics, and the vision is scaling up the complexity of interventions, starting from what we see at the primary care level. And the other thing is whether it's already time to think about including the new technology to help identify and monitoring the people, like using devices and artificial intelligence to see who would be those who need some adjustments in their pattern.
Yes, very good questions. So the treatment on adaptive treatment strategies was done at our internet psychiatry clinic, but it works. It's interesting because it's in specialized psychiatry, but patients self-refer. So it's an interesting setting. And that's the case for all our internet-delivered treatments, and we put up the studies that we do on the same website, so patients can self-refer, but also if they apply for another treatment, they go in there and they say, and then we can ask during the assessment, because there's always an assessment before and after, we can ask during the assessment whether if we think that they might be, or that this trial might be interesting for them, then we can ask them also. So it's a combination. Yes, but it's not primary care, but it's also not regular secondary care. So it's a kind of mixed. And the second question, sorry.
Was about incorporating new technologies,
yes,
such as devices and
yes.
artificial intelligence.
Yes, and that's a project that we're doing now. We're not doing it on insomnia specifically, so I didn't talk about it today. But we're doing that now, trying to use artificial intelligence to predict outcome, and then actually doing the same thing, because even with artificial intelligence, we've looked at different ways to predict, and regular prediction models are quite useful, and the artificial intelligence models before treatment start have not been stronger so far, not with the material that we have. So we do the same version. We start treatment, and then we have machine learning to predict the patient outcome. And what we're doing in this study is looking at feedback to the therapist, because it's the same type of treatment, again, with therapist guided and so forth. And we look at therapist feedback and see whether the feedback that they get will improve outcome for patients. So that's a continuous thing. So that's really interesting too. Yeah, future.
Thank you again for your talk. Just two questions. You mentioned that your patients were highly educated and also they are digitally competent.
Yeah.
What adaptations do you think we need to do to target patients with lower education level, or perhaps subsamples of patients who are less competent with digital.
Yeah, very good questions. We're doing another study on that as well, where we're looking at, in Sweden, groups of patients who are who may come from different countries and may not have the same education level that we're used to in Sweden. And the adaptations that we're looking at now, and we're co-designing this with patient groups too. So it's the language, we want it to be super simple and to not include very complicated reasoning, just more, one comment was, just tell me what to do. So that's what we're doing. So this is what you should do. And now do it like this. So just very concrete, rather than, because the treatments that we've done before have been much more like you would have a conversation in a regular face-to-face therapy. So reasonings on this and that, and descriptions of the rationales, and sort of more words and more complex. So we've really simplified it like that. And this, the what we call the faster sleep, the very short treatment is already quite simple, but we can make it much simpler. We realize that we can make it much simpler and make it much more, concrete. So I think that's the main things that we will do. And also have a very simple interface, so not a lot of things to do, just so that the interface sort of guides you, so you don't have to make choices in there, you just do what you're told to do, so to speak. I think this is really, really interesting, so yeah, good question.
And the second one, at what point do you deal with the psychiatric morbidity that might present with disorders? Were these patients excluded from the studies, or at some point you had to do something else to deal with anxiety or depression or alcohol-related problems? Yes.
So at the Internet Psychiatry Clinic, we, at the assessment stage, we decide on which treatment the patient should start with. And so that's a collaborative decision between the therapist who assesses and the patient. So, and we give one treatment at a time. So we do that, and so if the patient comes in, they say, I want a depression treatment, and we assess them, and they have a major depressive disorder, and we say, okay, so but you also have sleep problems, which if we find that they have insomnia, for instance, which would you like to start with? And then we decide together which they will start with, and then they do that, and then we do the assessment at the end, and if they need to, they can do another one. But we don't do parallel treatments. So that's one thing. And in the studies, we do exclude more difficult psychiatric problems like psychosis or bipolar disorders, but otherwise patients can be included. Patients can have a depressive disorder or anxiety disorder, or so those patients can be included even in the studies. Yeah.
Thank you.
I'd like to thank you. Short comments. In our experience here, we started with psychoeducational meetings for the patients for 30 patients, and we give them a lecture and respond all the questions. In the beginning, when we don't have CBT for all, then the patients like, and we saw very good results, as you know, only with one meeting. Now we have in video in our site for the patients, available. They can reach anytime they want. They can see the video 10 times, whatever they want, with this psychoactive to insomnia. We have also short CBT, not only behavior and education. And in our project, there was a problem, Professor Orestes, because we had too much comorbidity. And we have to interview me and Andrea, experts in sleep disorders, all the patients, because there are lots of patients not well medicated, and they couldn't apply to the groups.
In our study, we use it. In our study, our patients have psychiatric conditions. It's not primary insomnia, but secondary insomnia. Yeah. Yes, sorry, yes.
Yeah.
But we have a lot of patients with depression, anxiety, bipolar disorders in our trial, and they all improve with the CBTI. So it's important to treat them.
Absolutely, I completely agree. Yes.
And thank you very much. It was very nice.
Thank you.
Perhaps in a few years we will have a very good internet-based device. In Brazil, we saw a difference in education. It was something that we don't know how to solve, because people that were more familiar with internet and things like that have more education level that came to us.
Yeah, that is an interesting thing, I think, because for CBT in general, education level has not been a predictor outcome, which it has been for other types of psychological treatment, but for CBT, especially behavioral treatments, we haven't seen that education is a predictor outcome. So the question is, how can we, like you were asking, how can we make the digital versions work for them too? So that's really important.
Susanna, congratulations for your great presentation. And I'd like can you talk about the impact of CBTI in psychiatric disorders, for example, for depression, for anxiety, for other, the CBTI too?
Yes, well, yes, thank you for that question. That's another project that I have, where we look at treatment of insomnia and other sleep disorders, because insomnia is not the only sleep disorder in the world. And patients in psychiatry often have other sleep disorders as well, especially sleep phase problems, and some have OSA, and So we've focused on the insomnia and sleep phase disorder, and we include that. And in some patient groups, we also include nightmare or unwanted nightly experiences. It can be psychotic symptoms or nightmares or things that happen during the night that you don't want to have. So we combine those things, so insomnia treatment, CBTI, with the use of light and darkness and anxiety givers, so meals and physical activity, and so we structure that and have the patients implement that regularly, and also how to deal with these nightly unwanted experiences. So we combine that into a treatment, and then we deliver as group treatments for patients with psychotic disorders, bipolar disorders, more complex disorders. And those, then we've seen, I mean, in our studies and in other studies as well, there are meta-analyses showing that outcomes from CTI are quite good. So the insomnia improves, or sleep problems improve, and in some cases you see improvements also in the psychiatric problems, which is very encouraging. So depression and anxiety, especially, you can see improvements. Not so much in psychosis or psychotic symptoms and bipolar symptoms. So that more research is needed there. And we've also looked at ADHD, and ADHD symptoms also maybe not so much affected, but at least this insomnia improves. So that's we can help people with their sleep problems with psychological treatment, and sometimes the concurrent psychiatric symptoms also improve, but not always. Yeah. So sorry. Talk a lot about this.
Thank you, Professor Susanna. Thank you, Arthur. Thank you all for coming.
Thank you very much. Thank you.
Go ahead.
I know that you were helping also.
Yes.
Nice. The helicopter.
Yes, thank you.
Obrigado por organizar, acho que foi muito legal.
Onde conhecer?
Muito bom, e acho que a gente pode depois pensar em outras apresentações aí.
Muito bacana, né?
Passa com a gente, assim, muito legal.
A gente aprendeu bastante.
Muito bacana. A gente tem, sente muito bom.
During the day, I'm a teacher of like,
Oh, really?
I lived in the US for 2 years.
E a gente tem uma próxima reunião que vai ser meio que dentro do programa maior do CISM.
I just didn't get it microphone because I was out of the country at all. We talk most about first of all, it's the internet, lots about something. Very peaceful, very smooth.
Que eu não tive.
I don't but I know that
Mas vai estar dentro de uma programação maior, então vocês não precisam estar tendo outras atividades. Tá bom, beleza. Eu tinha uma mensagem para a programação.
I think it's very important that I myself and also in terms of I'm very cultural and very make the person die. So sometimes, for instance, on your ability not to get to sleep. So right now, I say, hey, you know what? It's very natural if you intend to sleep at night, even. So I self-conscious stay dark.
Yeah, we use that, like I said, with special
Já foi. Having to my treatment is now working well because the patient doesn't